Hey everyone, I'm so excited today. I hope you guys are excited for our topic. If you don't know me, I'm Brittany, a nurse practitioner, and today we're going to be talking on a brand new webinar on the big three. So, as you guys know, I like for mine to be interactive. So, Hiva's here with us in the chats. We have plenty of things to cover and talk about today. And, most of you guys, if you've been in nursing for more than 10 seconds, you guys have seen this population with either the triad of hyperlipidemia, hypertension, and diabetes, or at least they have, one or two of the three. And so I know you've seen a lot of this material around for a while. However, I really wanted to just expound upon these three things, talk about those first line treatments, talk about the guidelines, and really just kind of go through with managing these patients because as they get, comorbidities added on, their care really becomes a lot more complex. So, all right, let's go ahead and get started. We have a lot to cover today in our time together. So, our first up is hyperlipidemia. That is just a quick and easy way to say too much fat in the blood. And so this is just a reminder on your normal cholesterol levels, right? It's normal. We really need to know our normals before we can really understand abnormals, right? So normal cholesterol range less than 200, triglycerides less than 150. Remember, triglycerides are often made of those carbs and sugars. So if they have diabetes going on, a lot of times their triglycerides can be abnormal as well. Their LDL, which is their good cholesterol, it's cardioprotective at 50 for women and 40 for men. And then we have, I'm sorry, I just misspoke. That's your HDL. And then your LDL is your bad cholesterol. Your bad cholesterol, we want it less than 100. So I remember H as high and L as low. So we want our LDL to be low. We want our HDL to be high. And again, 40 for men, 60, 50 for women becomes cardioprotective for those HDL levels. So this is just your normal run-of-the-mill chart. Types of hyperlipidemia. You guys know that there are two types, primary and secondary. First of all, our primary is going to be our genetic, our familial risk factors. Maybe they do have a positive apolipoprotein A or B, and you're seeing that they have some sort of genetic link. However, today we're mainly going to be focusing on the secondary type, which is more of a lifestyle induced. They can also have, a genetic component as well, but if they are not having those healthy lifestyles, then, we're like kind of looking more at these secondary factors. So things like dietary cholesterol, obesity, other medical conditions, and even some medications can increase the risk. And again, this is going to be most common onset in those middle-aged adults. So really just paying attention to your screening guidelines here is going to be really important. Again, just a reminder that our secondary cholesterol, hyperlipidemia can be impacted by those lifestyle factors and lifestyle modifications. So the things that we normally are talking to these patients about, decrease in saturated fat in their diet, exercise, that's really going to be giving them some bang for their buck if they have this type. So just what do the guidelines say for screening? Pediatrics, ages 9 to 11 and 17 to 21. You can see they'll get that couple time screening for hyperlipidemia. A lot of times this is a familial link, and they're going to be managed by specialty. Men starting at age 35, or if they have risks or family history of cardiovascular disease, right? Diabetes is included in that because that does increase the risk of cardiovascular disease. So, you're going to be screening your patients with diabetes sooner than 35. Women starting around age 45, that's when they're going to start their hyperlipidemia screenings. But again, those of risk with coronary artery disease will be done sooner. And if they're low risk, we can do this every 5 years. However, obviously, if they are, popping up as hyperlipidemia, if their labs are increased and elevated, if maybe their HDL is not to that optimal cardioprotective level, we're going to be screening them, more frequently if they're on medications. We need to be screening them every, 6 to 12 months and tracking and trending this as we go along. So just paying attention there to what your guidelines are. Okay, this is our tool. Um, I want you all to think about what tool you could be using. I really like this ACSVD risk estimator. MD Calc has something as well, so it's here for you. And this calculator is from the Framingham Heart Study, and it's going to help to guide our decision making on whether or not these patients with hyperlipidemia are going to qualify for some sort of lipid lowering agent such as statin therapy. So these are the two that I personally use, and I really think that these are good because it looks at the patient a little bit holistically. Like, for example, does this patient smoke? Is this patient diabetic? Is this patient hypertensive? And how old is this patient? It really puts in a lot of thought process for determining whether or not that this patient is going to be a good fit to go on cholesterol medication. It gives us the proper guideline after it gives us the risk calculation, and it's really a tailored plan for us to be able to share with our patient. It gives recommendations. So this is something that, I would definitely be saving. I would definitely be keeping in my back pocket and taking a pay attention here with these calculators. All right, so our ASCVD calculator is going to give us a percentage along with the guidance that we can share with the patient, like I just discussed. The number that we're looking at is the 10-year risk with prevention measures. So really looking at the probability of heart disease here. Low risk are those with 5% or less. We're just going to encourage them if they have hyperlipidemia to continue with a healthy lifestyle, recheck it in 5 years, kind of see where they're going with that. This patient here, borderline risk, 5 to 7.4%. This is a great spot to be really making some of those lifestyle changes. This is really one of those who we are trying to catch before they become a true risk and have to go on medication. So this is a place where we can kind of, is their blood pressure controlled? Have they stopped smoking? These types of things that we can do with the patients at that borderline risk. And then also, depending on comorbidities, they may, in this borderline risk category, still qualify for a statin if they're, like, say, have diabetes. Now, intermediate risk is where we start really offering statin therapy for our patients. So if their risk is 7.5% or higher, these patients need to be offered a statin. And again, looking at the 10-year calculation there, that's going to be our threshold. And we're going to encourage lifestyle changes just like we do everyone else, but they probably are going to be going ahead and offer them a statin and just kind of seeing where they go. Usually it'll be a moderate intensity statin, and that little calculator I just shared with you will tell you if they recommend moderate or high intensity statin. And then a high risk is going to be greater than 10%. These patients are going to receive a high intensity statin immediately. We're going to really implement an aggressive lifestyle change here. And for risk mitigation, we're going to go ahead and just give them that support in the interim. And one thing that I want to just say on a caveat here, if your patient has suffered from a cardiovascular event such as MI in the past, go ahead and prescribe a high intensity statin regardless of their risk factor because they already have sustained some damage, and we're really trying to decrease the risk of recurrence here. So we want to keep the plaque that they do have stable. So they're going to be offered a high intensity statin regardless. So just FYI there. All right. Statin intensity, let's talk about that. So again, this calculator is going to give you the guideline, and it's going to tell you, moderate, high intensity, whatever it be. And the good news is there's only about 8 statins. That's our first line treatment of hyperlipidemia in addition to lifestyle change. And the difference here is that if you're familiar with these 8 statins, then you are just going to mainly know the different intensities, and how it increases in intensity is by milligram dosage. So it's really pretty easy here. So for example, Lipitor at 10 to 20 milligrams daily is a moderate dose. So I might prescribe that one with someone with like an ASCVD risk calculation score of 8%. However, that same statin can be used for high intensity. And so maybe someone that is a smoker with diabetes, they're up in the 10s, 11s, whatever it be, probably going to be prescribing Lipitor at a higher dose. So you can see here that I am increasing this same medication, and it's just increasing the intensity. Excuse me. So just being aware of that, knowing that, there's just a few statins in your back pocket that you have, and that you can really tailor your dosing. All right. So, we talked about statins being our first line option for treatment here. And there are several other, excuse me, several other drug classes that we have. Some people may not be able to tolerate our statins, and so we might use another class such as bile acid sequestrant. We can add these things on to statin therapy. So one of the things that I'm going to ask you guys to put in the chat is, what can we add on for triglycerides? Do you guys know the answer to that? I want y'all to put that in the chats of what we can add on for triglycerides. Excuse me. Absolutely, absolutely. That is going to be either something like an injectable, like a Repatha. We can also add on those fabric acids. So, gemcitabine, something that is fenofibrate, it's going to decrease the triglycerides. But I do want to give you a word of caution. Be careful with combining those with statins. These patients need to be monitored a little bit closer. And who can tell me, let's talk about some of the side effects of statins. So let's talk about the side effects of statins. Excuse me. So who can tell me about the concerning signs of rhabdomyolysis or drug-induced hepatitis? So who can put that in the chats? Tell me about these emergent conditions here. So rhabdomyolysis is going to be one of the rare ones. We want to see looking for things like dark urine, muscle pain, and this one is really going to be a breakdown of the muscle tissue, and it is a medical emergency, and some of the presenting signs may have a severe muscle pain or dark urine. And then we also are going to go ahead and send them to the ER. The drug-induced hepatitis can have the ALT elevation, the jaundice, the abdominal pain, and really and truly, one of the ways that we can be screening for these things is about 30 to 60 days after starting a statin, is going ahead and ordering a CMP, which really isn't a bad idea. Just about really any of the drugs that you're given for these big three things today that we're talking about, to order that CMP, just checking their kidney and liver function, checking to see. It'll give you a spot check glucose if you're starting, diabetes medications, and just kind of making sure that all of their organs are functioning well and that you don't have anything to be concerned about. So just something to kind of be mindful of here for when you're initiating statin therapy. All right, so your role as a nurse practitioner is going to really be thinking about assessments, thinking about taking a good family history, looking at differential diagnosis, primary versus secondary, kind of helping to weed that out, and then also running your risk calculations and making sure that you're tracking and trending those levels. Who can put in the chat some things that you might see for our patients if they are coming in with hyperlipidemia? Maybe it's been untreated, maybe it's been treated. I want you to think about some assessment findings that you might find. So I'll give you a minute just to think and put that in the chats of what you think some of your physical assessment findings might tip you off that this patient could have hyperlipidemia. Maybe they're a new patient and you haven't seen their cholesterol level yet. So that's right, absolutely. So things like, bruise on the carotids, high blood pressure. What about the eyes, right? That's right, xanthelasmas, the obesity. So these things right here can be things that can really tip us off that patient might be having hyperlipidemia. So great job, guys. Okay, we're going to move on to hypertension. Y'all can put any comments that y'all have. Again, Heva's still with us. Thank you, Heva, for your help today. All right, so let's talk about hypertension. Again, we're going to look here at a bird's eye view. High risk for death and disease. Cardiovascular disease worldwide is a silent killer. It goes unnoticed for years. The damages are often done before we even know it. Deemed the silent killer, hypertension is, because there's usually no, physical, symptoms that these patients are having until it's really progressed. So again, looking at your blood pressure screenings, how many times when patients come in are you taking vital signs? Most likely every time, right? And so this is something that we can kind of easily track and trend, easily treat, and really help mitigate issues as these patients go along. So again, knowing your normals, this is from American Heart Association. They've kind of updated this recently. So normal is going to be 120/80 or less. And then we would say elevated for 120 to 129 over, less than 80. And then we have stages of hypertension, stage 1 and stage 2. And then really when we get at that 140/90 threshold, we really need to be looking at making sure that those patients are, in addition to their lifestyle changes, offered medication. And then hypertensive crisis, that means go to the emergency room, bypass my office, and go ahead and go 180/120. Anybody who has a reading of blood pressure like that that is not coming down or they're symptomatic needs to go on to the ER. So just making sure that when you are talking to your patients about blood pressure that you are letting them know when to call, when to come, and when to go to the ER. So the Joint Commission, Joint National Commission, JNC8, also puts out some guidelines. These are a little bit older guidelines. This is currently being reviewed for best practice. And you can see on here, again, if it's older population over 60 years old, 150/90. So they have a little bit looser guidelines there. 140/90 for the general population or those with diabetes or CKD, younger patients. So just, again, this is kind of, they're working on this still for updates, but this is kind of been around for a little while. It's a little bit less widely used, but just so you know, it is there. And, with guidelines, as I always tell you guys, pick one and go with it. You don't have to memorize all the guidelines, but just pick one and go with it so that you're well versed in that. Okay, so for measurements of blood pressure, you guys know we're never going to give a blood pressure medication just because we capture an elevated blood pressure in the clinic one day. These patients could have white coat or they could have true hypertension, and that needs to be sorted out. Maybe they were just rushing and they're stressed in traffic. Maybe they're in pain. So we're not going to just rush and give them blood pressure medications. They are going to, if I get a high blood pressure reading in clinic, I'm going to recheck it while they're there. Sometimes it comes down, right? If if they're anxious or whatever when they first get here, maybe they were rushing. Sometimes it has come down. We also are going to send them home with a blood pressure log. We're going to have them to come back in about 2 to 4 weeks after they've checked their blood pressure, every day or maybe morning and afternoon, and just kind of gotten us some trends of kind of what their blood pressure is doing. And then also we're going to have them to come back into the office and we're going to kind of look and see, where is it at? What's it running? 140/90 or higher on 50% of those readings. Definitely needs to be offered, blood pressure support there. Okay, so this is just a reminder here that we have primary and secondary hypertension, just like we do in the sense of hyperlipidemia. Primary is going to be, environmental, genetic links, behavioral. So it's a little bit different. Smoking, diet, and obesity is going to still be primary cause, right? But secondary is going to be some other issues going on in the body, and the hypertension is secondary. So maybe they have a renal issue or a vascular or endocrine issue. So, maybe they're taking a medication that raises their blood pressure. Did you guys know NSAIDs can raise your blood pressure? So secondary causes are going to be something else that's going on, and that blood pressure is increased. Hypertensive emergency is going to be anytime someone has an unexplained rapid elevation of blood pressure. If Mr. Jones comes in and his blood pressure is always 130/80 and he's well controlled on his lisinopril, all of a sudden his blood pressure's 175/100 on all of his readings at home, we really need to be doing a little bit more workup and find out what is going on, and is this kind of a primary or a secondary issue. So just something to be mindful of there. All right, so target organ damage. You guys know that blood pressure issues and hypertension can impact every single organ system in the body, as well as diabetes. Target organ damage with uncontrolled hypertension primarily affects the heart, kidneys, brain, and eyes. And you guys know cardiac manifestations will include things like LVH, or left ventricular hypertrophy, which can be seen on an EKG. Coronary artery disease, aortic dissection, that's that ripping, tearing sensation patients will get, and also valvular diseases. So are you listening for those murmurs? Are you seeing, if that heart is stiff when you're doing your assessments? In the kidneys, renal failure, nephropathy, proteinuria can occur, and in the brain, hypertensive patients will be at risk for those hemorrhagic or ischemic strokes, small vessel disease, vascular dementia, and cognitive impairments. And then, of course, you guys know optic neuropathy and retinopathy can occur. And so really the risk factors here are very complex. We don't fully understand this, but, just knowing that they can, this hypertension can impact the entire body. It's a multifaceted approach to evaluation and management of hypertension will be important. So that's your key takeaway point there. All right. History and physical. So, we talked about how this can be kind of deemed the silent killer. Often this goes unnoticed. And so the patient can be presenting with some sort of hypertension-related complaint, or they may not be even seeing you for that. Maybe they're there for, the flu, or maybe they're there for, a UTI. And so, you really are going to be in primary care, urgent care. You're going to be really that first line gatekeeper to kind of be screening and, educating your patients out in the community of what is a normal, healthy blood pressure reading. So, you might note the blood pressure is elevated, but then you're going to inquire about some more specific details. And you guys want to look at those primary signs of target organ failure. So things like, chest pain, their medical history, what is their blood pressure reading, did you do a little eye exam? And then also, how about your cardiac exam? What are you noticing there? So also, I'll just point out here, thyroid enlargement. What do you guys know about the hyperthyroidism? How does it affect the heart? So something that you all just kind of want to be aware of there with underlying thyroid issues. Okay. Workup for, you're looking for, again, target organ damage here. So you're going to want to perform your basic lab tests. You're going to get your complete blood count. You're going to get your comprehensive metabolic panel, your analysis, again, mainly looking for things like proteinuria. Your A1C, is this patient, getting their diabetes screenings done? And then your cholesterol panel, again, that goes back to what we just talked about with hyperlipidemia. Oftentimes this stuff kind of goes hand in hand. A 12-lead EKG, most of the times insurance will pay for EKGs and echocardiograms if the patient has hypertension on their chart, because again, we're really looking to see, do they, are their valves getting tired, or is their heart getting stiff? Do they have LVH? That's that stretching out of that bottom left ventricle there. What's going on. And then renal ultrasound, especially for those that we just talked about that we think it could be more of a secondary issue, especially those who, we think that their blood pressure has really risen up and they're all of a sudden not being controlled, may consider renal ultrasound, also CTA of the chest. So just some different workups depending on what you think is going on with the patient will be appropriate. And then once your patient is diagnosed and properly worked up, you're really going to want to discuss management for their blood pressure. Obviously, if it's at that 140/90 on 50% of the readings, I will go ahead and offer, blood pressure support. But again, our first line treatment for when we can try to capture this before it gets too bad is our lifestyle modifications. So thinking about, knowing that lifestyle modification is going to be one of our biggest first line treatments for a lot of things, especially these three things that we're talking about today. So this should be really just part of your routine discussions. Encourage all of your patients to follow this. So making sure that these patients are, getting in their movement each day, that they're at a healthy weight, that they're on a heart healthy diet, they have minimal alcohol, and then smoking cessation. One of my favorite questions to ask my patients is, what can I do to help you to cut down or stop smoking? And some of them will say nothing. Some of them will say, nicotine patch or medication or whatever. We really want to champion these patients and really empower them so that we can set them up for success. So just paying attention to how these lifestyle modifications can really impact these patients. And my thought is first of all, I always talk to my patients about, even if you are on medication, if you make lifestyle modifications, we can, pull back that blood pressure medication a lot. And, I'd much rather you be on, 5 milligrams versus 50 milligrams, or I'd much rather you be on blood pressure medication at 65 versus 35. So I really just talk to the patients about, I want you on the least most effective dose. And with coupling this with lifestyle modifications, it's not just a free pass to just go out and do whatever you want. So just talking to these patients and, really just, again, trying to empower them, set them up for success, answering questions and education, because that knowledge is really going to be key and power for them. All right. You guys know, y'all have seen these, again, the antihypertensive medications. Of course, you're going to have your ACEs and ARBs at the very top. Also think about the grade of blood pressure elevation, but also risk factors such as cardiovascular disease, diabetes, chronic kidney disease, 10-year calculated ACSVD risk calculation. Above 10%, we're going to offer them a little bit of blood pressure support. And then also over the age of 65, we don't want to, swing them in the wrong direction and make them become hypotensive. So really just paying attention to, using your drug classes appropriately, really paying attention. Beta blockers can impact, those with diabetes by impacting their sugar levels. So just really paying attention and trying to pick out the best class. But again, knowing that your top two classes for most people, unless they are childbearing age or that angioedema or their really dry cough bothered them, it's going to be your ACEs and ARBs. So just paying attention there and really kind of digging in, looking over your drug classes and knowing that, how they work. That's really going to help you for your board. So just a little tip there. All right. Let's take a look here. I don't know why I've got the JNC8 in there both or two times now, but I do have one here for your treatments. So again, these are being looked at, but in times past, African Americans, we've thought about thiazide diuretics or calcium channel blockers as first line. Other ethnicities, the thiazide diuretics, ACEs, ARBs, calcium channel blockers. And remember, some of these come in combo pills, like, for example, lisinopril and HCTZ. That's going to bring in a thiazide diuretic as well as an ACE inhibitor. So, you can have those combo medications, and ideally we are using those as kind of that first, second line there. I would do one at a time, but, if the lisinopril alone's not covering it and we want to add on a little bit of diuretic to it, then we're going to go ahead and we're going to use a combo pill if that's available to us. And it's, appropriate for the patient. Patients with diabetes, patients with CKD, again, that ACE and that ARB drug class is going to provide that extra renal support for those patients, especially if they have things like proteinuria, or microalbumin, creatinine ratios increase. So that is something that we can help to protect their kidneys by using those drug classes, because that's evidence-based practice. We already know that. All right. when do we refer to cardiology? So, not every patient who is on blood pressure medication is going to be going to cardiology, not by a long shot. So if we start seeing things like hypertension is just refractory, we just can't get them managed no matter what blood pressure medication, if they're on more than, two or three things, I'm already thinking about to myself, let's get this patient over to cardiology, see if we can get their meds out in a little bit better. Again, doesn't respond to multiple drugs. Cardiac conditions complicate the treatment. So maybe they do have hypertension, hyperlipidemia, and they have had some, heart attacks or things like that. I want them followed by cardiology, if for nothing else, making sure that we're tracking and trending those EKGs over the long term, making sure they're not having a lot of changes there. Secondary causes, again, you need to think about, if it's endocrine cause, because it's thyroid, that patient's going to be going to, endocrinology. But just, you can see kind of where they fall in with the specialist there. Pediatric patients are going to be managed by pediatric cardiology every single time. And then pregnancy patient, we're going to be co-managing with OBGYN. So who can tell me in the chats what are some safe blood pressure medications for those pregnant patients? Do you guys know the answer to that? Who can tell me? I'll give y'all just a minute to think about what are some safe blood pressure medications. Absolutely. Yep. You got it. You got it. So I remember that by the alphabet, LMN, right? And that is going to be L for labetalol, M for methyl-dopa, N for nifedipine, right? So LMN, that's going to be, if you say LMN, skip over O, and then say P, that's going to be safe for pregnant patients. So just a little mnemonic trick to help you remember there when you're taking your boards. All right, so now we're going to jump right into diabetes here. And we're going to just briefly talk about that. Hiva, you can feel free to jump in here. Hiva is an expert on all three of these topics, and she especially loves diabetes, I know. So you can feel free to add anything you'd like to add in either the comments or come on and talk. So, you guys know that we have two types of diabetes, type 1 and type 2. So today, everything has these different types, right? So this is just going to be broadly defined as chronically elevated blood sugars. And type 1 will be more of that autoimmune response. These patients are going to be insulin dependent. Beta cells are destroyed. And so this is, a smaller number of people in the population, 10% of cases, often mostly diagnosed in childhood, but we have seen some cases where the patients are older. And then type 2 is going to be the other 85 to 90% of cases. This will be metabolic dysfunction. Again, the beta cells are still destroyed or damaged over a longer period of time because they have developed insulin resistance, insulin deficiency, and this is actually, due to some sort of metabolic dysfunction. And remember, you cannot regenerate beta cells, right? So once they're gone, they're gone. That's a question that I get all the time is, well, how do we regenerate my pancreas? The answer is it doesn't. So, so really just conserving and preserving that function as best as we can. If that patient's starting to march towards diabetes, and they're in that pre-diabetes range, we really want to try to preserve, function for as long as we can. How we're going to do that is just going to be, lifestyle changes, thinking about modifiable risk factors. And then, if that patient is just popping up as pre-diabetes, you still are going to monitor and screen for those cardiovascular disease risk factors like we just talked about. You guys know signs and symptoms of diabetes if you've been in nursing for more than, again, 10 seconds. But signs and symptoms are pretty much going to be the same for both, but increased urination, thirst, and hunger. So you guys got that polydipsia, polyuria, and polyphagia that y'all read about in the textbook. That's just a fancy way to say those. Thrush or, itching, slow wound healing, blurry vision, just fatigue or weight loss. These are just things that, again, metabolic signs and symptoms here. This all makes sense if you think about, the disease process and the pathophysiology of diabetes. And pretty much, the body's trying to, lower those levels of glucose and get rid of it through the kidneys. And so, that's why those people with a lot of uncontrolled diabetes, always are going to the bathroom. So, and then of course they're thirsty and it just creates that vicious cycle. So anyways, just paying attention there for your signs and symptoms. And then what is a normal hemoglobin A1C? So normal is going to be less than 5.7. And then prediabetes will be 5.7 to 6.4. And then diabetes is going to be greater than 6.5%. So really just paying attention to what your A1C is. And remember, that's that snapshot of what, their blood sugar has been running. All these have a correlation. And so, what is their average blood sugar? So you can look on the ADA website and there's a correlation chart there for you of what their average sugar is. And I like to pull that up and talk to the patients about that. When we're talking about their A1C, kind of like, well, this is kind of where your blood sugar's sitting. So just knowing your A1C ranges. And again, every 90 days we can check it. Lifespan of a red blood cell is around between 90 to 120 days. So that makes sense as why we would screen an A1C, for somebody who were really trying to get dialed in on their medications or, maybe try to move them from pre-diabetes back to normal range. If they're just there at the borderline threshold is, every 3 months. So just paying attention there. And then your guidelines for treatment of actual type 2 diabetes, they can seem very daunting at first, but there are two main bodies of evidence for us. And the guidelines available are algorithms. They're going to help guide you in selecting the appropriate medication regimen for your diabetic patients. And today we're mainly going to be talking about just first line treatment for diabetes, because you guys, you can get really in the weeds on this. And today, again, I really wanted to talk to y'all about first line treatments for these big three things. So that's kind of what we're going to stick with today. All right, so these guidelines are really going to help you navigate board questions, management of patients as you begin your practice. They're a bit in depth, and so we'll just keep them, surface, but I would say keep them as a reference. First of all, A1C goals, those without other major comorbidities for an A1C goal is going to be 7 to 7.5%, and that fasting glucose target range of around 117 to 135. And then for frailer older adults, they get a little bit more leeway because, again, we don't want to make them become hypoglycemic by over-treating them with medications. And so their goal is going to be more of like that 7.5 to 8.5. But again, we don't really want anyone over 9 on their A1C. So just something that, and that's when we kind of start thinking about insulin when we get in the 9s. So, really just paying attention to how old is this patient? How strict do we need their goal to be? If they're younger, I want them on a tighter goal. If they're 38 years old, I want them down in the 6s ideally. But 7 can be their goal. If they're elderly, they're going to get a little bit more leeway. And then pharmacologically, our first line medication is going to be metformin. You guys know about metformin. And then we can always add on some secondary drug classes based upon guidelines or individual factors. So let's talk about right now kind of, some of the main treatments for diabetes that we're seeing in practice. So, first of all, biguanides, the one medication that's in this is glucophage. That's the only, or metformin, that's the only biguanide available in the U.S. And this drug acts on the liver to reduce hepatic output of glucose, decrease absorption of the glucose in the intestine, and increase uptake of glucose in the peripheral tissues. So it's all about the glucose here. Primary adverse reactions are going to be GI. So think about things like diarrhea, nausea. And so I really like to start this low and go slow. So you can see here on the dosing, initial dose will be 500 milligrams a day. They're going to take that with their largest meal. They're going to drink plenty of water. And we always just want to let the patients know that they will have some GI side effects most likely. There are some extended release versions of this. I've even seen it given in a gel before to bypass the stomach completely. And so there are a few little workarounds here, but basically you need to just watch and warn them that they may have some GI effects. Usually this will decrease after the first couple weeks on it. And so then they can start adding maybe a morning and an evening dose to get up to 1,000. And that's kind of that initial dosing of metformin. The max is going to be 2,000 milligrams a day. And we really need to watch their kidneys on this patient. When that GFR starts getting around that 45, we want to be careful. We want to stop the metformin and look at other alternatives. And then there is a black box warning for lactic acidosis, especially in patients with the kidney disease, the elderly patients, and patients with hypoxic states, like think about COPD. So just be mindful there, and you're going to avoid that. So, all right, let's take a look here. So at the beginning, you might have saw on that slide, I didn't say anything yet, but MET 1, 2, that's how I kind of remember my stepwise original treatments for diabetes, very first line, run of the mill. Again, you need to, tailor it for your patient. But this is something that, you can kind of keep in your back pocket of kind of, where to start. So again, for type 2, type 1 is going to be insulin. It's going to be if you need to add on after metformin is you can look at either a GLP-1 or an SGLT2. So MET 1 and 2. So GLP-1s, these are a very hot commodity right now. You guys have heard them, I know, around on the market as, Trulicity, Victoza, Ozempic, semaglutide, same thing, Zepbound, Mounjaro. You guys know all these names. Everybody's wanting to get on it because of that delayed GI emptying, which is going to help to bring slow their GI motility down. And it's going to help maybe aid in some weight loss. And we'll talk about that here just in a minute. And also, you want to really screen for thyroid issues with these patients because in rats, these medications were shown to show thyroid cell tumors, including medullary thyroid carcinoma. So, the risk hasn't really been determined in humans much, but I do screen like, hey, do you have any history of thyroid or pancreatic cancer? It's going to be contraindicated. Also, multiple endocrine neoplasia syndrome, again, going to be contraindicated. So we don't want to, do anything that's going to increase the risk of developing tumors. These have some black box warnings on them. So I want you to be thinking about this. The first one is going to be GI, decreased motility causing bowel obstructions. So I talk to my patients when you're first starting this, decrease your intake by 50% till you see how this medication affects you. I tell them to drink plenty of water, increase their fiber intake, can use a little bit of Miralax when they're first getting started on this. Again, starting low and going slow, 0.25 milligrams in your first month, then 0.5 milligrams your second month, and then we're going to have a follow-up. So, these have a black box warning on them. I always tell the patients that, we don't want to induce you to have so much weight loss and then a bowel obstruction. So paying attention there. And then also suicidal thoughts. The FDA has been getting some reports of that. They're investigating this issue. And so it's not really, it's kind of undetermined, but it's something that we kind of want to be mindful of. So if your patient has like a huge history of depression, really need to be, thinking about that for these patients. again, these stimulate insulin, the release of insulin, and also inhibit the inappropriate release of glucagon after eating and reducing food intake. And so therefore, it does help with weight loss in that way. And then also studies have been looking at the lowering of the ASCVD risk with the use of GLP-1s with patients with type 2 diabetes. So again, a good drug class when used appropriately, when titrated appropriately, when monitored appropriately. So again, this is a hot commodity. It's right for a lot of people. It's not right for some. So just paying attention there and really weighing the risks versus the benefits before you prescribe this. A1C reduction in this class is about 1 to 2%. And so that's pretty good. So, a lot of patients are having some good results, and then they have that secondary effect of weight loss with it. So popular drug class here. So if they are on metformin, and we need an add-on, because they're just not to go, and a GLP-1 is not appropriate. Another class you might look at is SGLT2 inhibitors. And then this drug class basically has their effect on the kidneys by inhibiting SGLT2 proteins, decreasing the reabsorption of the glucose in the proximal tubules, and reducing the renal threshold for glucose and promoting the glucose excretion in the urine. These usually work a little less effectively by lowering the A1C by 0.7%. But again, these patients, I would like to remind you, we try to avoid this drug class in the elderly and those with renal impairment. So again, may not always be the best choice because these can cause hypoglycemia, especially in the elderly. And then also they have gotten some traction lately for those who are even not diabetic, but especially if they have diabetes and heart disease. They can be used for people who have CHF, congestive heart failure. So we're really seeing like Farxiga and Jardiance given, and it helps to, mitigate some of the effects of the heart failure. It helps to provide some cardioprotection. So, some good research coming out there. So again, depending on if the patient has other comorbidities, obesity for GLP-1s or heart issues with the SGLT2s, you can kind of help to, steer you on where you want to go. Of course, nothing goes unpunished without some side effects, increased urine output, which then therefore can lead to yeast infections, UTIs. Again, thinking about the elderly, we want to try to avoid that. Of course, hypovolemia, because we're helping with the CHF, but we don't want to, deplete them of all fluid. Increased potassium and weight loss. So, really watching for dehydration and infection, specifically UTIs and yeast. So just paying attention here. And if you do get a urinalysis on these patients, just so you know, these will pop up positive for glucose in the urine, and it's most likely related to their medication. In fact, working at an urgent care, or working in primary care, I had a patient come in and say, urgent care sent me here for glucose in my urine. And then this patient was on Jardiance. And so that's what was causing that most likely. So anyways, just something that we want to, be mindful of. All right, complications of diabetes, something that you want to look at and see. Over time, high glucose levels can cause damage to the tiny blood vessels, and retinopathy can lead to things like blindness. So therefore, all of our patients with diabetes, we're going to try to detect it early by having them in with the eye doctor every year, even if they don't like wear glasses. Neuropathy, you guys know that, where their feet especially, or other limbs can have that painful sensation, decreased sensation, making sure we are checking sensation when these patients come in at least yearly. And so just paying attention, because this can be very painful for these patients. Oftentimes, that nervous system will malfunction. They'll have that severe pain. These patients often will have to be on medications like gabapentin, Lyrica, Cymbalta to kind of try to calm that nerve pain down. Diabetic foot ulcers, if their sensations decrease, then they may be stepping on Legos or whatever they got lying around the house, and it can create ulcers in the feet. The blood flow is going to be poor. The nerve damage already that they have underlying can lead to things like infection, amputation, and these non-healing ulcers. And so, just providing foot care, are they using a partner? Are they using a mirror to help inspect their feet, keeping their feet dry, not soaking their feet, not getting, pedicures at, places, just, around town that can help to decrease, or that can help to increase, foot health. Nephropathy, that's going to be that kidney. Are you checking a microalbumin and a creatinine ratio on your patients every year? Are these patients offered support with a ACE or an ARB if that's elevated? I would say like over 30. You need to start thinking about that. Eventually can lead to things like end-stage renal disease, dialysis, and so just paying attention to that. Erectile dysfunction, we've talked about this before. Specifically, you guys know that there's that international index of ED that you can use if you don't want to like talk to them about it and they just want to kind of fill out a questionnaire, knowing that diabetes can cause, decreased vascular, function, if you will. And so it's not just in the legs and feet. It can be in any organ, in anywhere in the body. Helping them to bring those sugars back down, good glycemic control, making sure their blood pressure is controlled. That can help with some of these things that we're seeing here, because again, on our big three, these things can kind of all go together. Also, just educating your patients is going to be your number one thing, because, carrying the risk of many complications and target organ damage. So again, just educating your patients, signs and symptoms to report. When do they need to call? When do they need to come in? And when do they need to seek emergency care? So just paying attention to those things, you're going to be all right. All right, we're going to tie it all together here on this last slide. Can you all believe you've made it? You've done a great job today. And first of all, diabetes increases the risk of medium and large arterial wall damage. Atherosclerosis can therefore lead to what? Coronary artery disease, right? Heart attack and stroke will be major contributors to the mortality and morbidity of these diseases. And then also macrovascular complications of diabetes, hypertension, hyperlipidemia can also, go hand in hand with stroke. And so this is something that you all want to pay attention to. Also, all these patients should be, regularly screened for coronary artery disease risk factors, at least annually. And the other thing is I've put some other screenings here for you guys. We've talked about just about all of them, but, this is what you need to be adding to your notebook to be checking on these patients. Do they have that baseline EKG? Are they getting their creatinine and GFR checked annually on a, at least annually on a CMP, more often. That's the bare minimum. More often and better. Are they having their cholesterol assessed? Are they having their eye exam? Are they getting foot care? Maybe they follow with podiatry. So this is something that we definitely want to talk with our patients about. This is something that these screenings are what we want to add to our, order sets that we're doing. This is what we want to add to our notebooks. This is what we want to add to our studies, so that we really know how to interpret these and really educate our patients on them and make sure that we're doing the appropriate screenings, because this can all be, turn into a perfect storm and a complex patient. So just something that we want to be aware of. All right, so now we're going to go ahead and move into Q&A. Before we do, I have a very exciting announcement for you guys today. And basically, this is just, we're promoting the SurePass. This is something new that Archer has launched. It has the Q Bank and an on-demand and a live review. For those who don't know, the live review is going to be, there's going to be one this weekend coming up. So if you are interested in signing up for that. I think there's still time. You all can scan this QR code here that I've put here for you to register for this SurePass. All that you need for exam prep. There is a pass guarantee on here. The question bank, again, we're always doing that free trial. We've got over 1,600 questions. We've been working to scrub really hard those rationales and put some, good videos in there for you all. And it gives you a readiness predictor. That's something that is kind of significant to Archer. On demand, I know that Heva worked so hard to help with that. Heva, you can probably answer their questions more about that than I can. Over 13 hours of content in bite-sized videos on the go. If needed, in-depth coverage on every topic. Again, when you come to these live reviews or you come to the webinars, sometimes it's more of a bird's eye view, but they really get down to the nitty-gritty for you, so you can really understand the whys behind all of these things that we're doing as nurse practitioners. And so, these are just some really exciting things. The SurePass kind of bundles all of that together just for a really nice package for you. Again, this is kind of something new that Archer has done, and I just think it's wonderful. So check that out. Also, we would love to connect with you. We are currently making question of the days, different things that we're putting on our social media accounts. If you have social media, you need to follow Archer Review. We are trying to put out content for you to kind of study as you're scrolling, if you will, and give you some little helpful tips in just those 60-second reels. We often will advertise things like, this webinar or the upcoming live review or whatever. So you want to be in the know of what is going on here at Archer. And so, as always, we want you to email us for questions. We've put here questions for you guys. Also, next week we're going to be having some exciting things come out for this very webinar. Actually, we're going to be having a panel. He was going to be joining me again. We're going to have Morgan with us. So just a lot of really exciting things that we have coming up at Archer that I don't want you to miss. So take a minute, scan that QR code, and connect with us on social media. And then, of course, we love to hear from you in the form of emails as well. So let's go ahead and go on to our practice questions. And you guys can go ahead and put that in the chat, and we'll go over each one. So in planning pharmacologic treatment for a geriatric patient with diabetes, which of the following should be considered? So A is going to be sulfonylurea, such as glipizide, should be first-line therapy. B, insulin gargline or Lantus insulin is going to be preferred. C, combination therapy. Or D, a single medication of metformin. So what are you guys saying? Absolutely. Yes, you guys got that. Y'all listened so well today. That's right. It's going to be D. So very good. So A, sulfonylurea falls in the elderly, right? It's on that Beers criteria list. B will not be first line. 3, again, thinking about hypoglycemia if you're starting to give them a lot of medications together. And then D is going to be that single med with metformin. That's going to be your safest route, or your safest one, especially for your geriatric patient. Starting them low and going slow, right? Okay. So this is a 47-year-old comes in for a follow-up 1 month after starting atorvastatin 40 milligrams. New onset of muscle cramps, dark urine. Which test should we order along with that comprehensive metabolic panel? So I didn't give you the exact one, but let's see how much you know. Check the chats. Absolutely. Absolutely. That is going to be A, that creatinine kinase level is over 5 times the upper limit of normal. Is going to be telling us to send that patient to the emergency room. Remember, CK is showing the muscle breakdown, which could be indicative of rhabdo. So you guys got that? No tricking you there, huh? Okay, let's take a look here. This is Miss Jones, 35 years old, 6 weeks pregnant, due to see her OBGYN next week. Then you guys got this earlier. So the nurse practitioner notes on her medication record she's taken lisinopril 10 milligrams daily. Which hypertension medication could the nurse practitioner consider a safer alternative? So what y'all putting in the chats here? This is a select all that apply, so pay attention there. Absolutely. You guys got it. Very good. Labetalol, methyl-dopa, nifedipine, LMN, just like the alphabet, right? Losartan, ACEs, ARBs, statins, DMARDs. We're going to avoid all those drug classes in pregnancy, aren't we? You guys got it. Okay. So Mr. Kendrick is 72 years old and a history of hyperlipidemia, comes to your clinic for follow-up. And the nurse practitioner auscultates a bruit over the left carotid. Which initial imaging would be used to verify plaque in the carotid? So what y'all thinking? X-ray, CT, ultrasound, or MRI? Absolutely, absolutely. Ultrasound, very good. That's going to be able to detect that plaque. That's going to be that first line imaging we get. CT or MRI image of the vessels, may be run by cardiology, but the stem of the question wants to know the initial imaging test. So ultrasound is where you're going to start. So again, we can't pull anything over on them today, Hiva. They're getting it. All right. So what do y'all think here? 54-year-old comes into the clinic for annual wellness visit and lab work. Cholesterol panel is as follows. Total cholesterol 270, triglycerides 692, HDL 54, and LDL 143. You're going to go ahead and prescribe fenofibrate to reduce the triglyceride level and prevent what condition? So increased triglycerides up over 500. That's going to be your key here. I think we talked about this one, but you guys probably know it if I had to guess. So go ahead and take your best guess. See what you got. Okay, this one was a little bit trickier, but you got it. Some of you got it. B is correct here. This is pancreatitis. We did not cover this in the lecture. This is just a little bonus question for you all. Anyone with triglycerides up over 500, we need to be educating them on, not taking alcohol, not having a lot of foods with a lot of fat in them is because this can create pancreatitis, which is a very painful condition, a lot of abdominal pain. We want this patient to watch their sugars and carbs, and we're going to go ahead and start him on the fenofibrate and recheck here in another month or so. That's CMP, and might also get an amylase and lipase to check pancreatic function. And the other things on here are complications to watch for in patients on statin therapy, the jaundice jaundice, rhabdo, and drug-induced hepatitis. Those are the things to watch for on statin therapy. This patient's starting fenofibrate, and it's still a cholesterol medication, but the concern here is pancreatitis because his triglycerides are up over 500. So very good, you guys. Very good. I hope that you all have had a good time today. I know I have. We're looking forward to seeing you all coming up this weekend. For those who are coming to the live review, we are looking forward to seeing a lot of you guys signing up for SurePass, connecting on social media, continuing to come to our free live webinar events. So we have all kinds of exciting things. Again, if you have any questions or we can be of any help to you in any way, feel free to email us any of your questions at nursepractitioner@Archer Review. And I'll hang around here for just another minute in case anybody has any other questions or concerns. And otherwise, we'll let y'all go. I hope y'all have a good rest of your day.